Hey, good afternoon, everyone. We are at our 2 p.m. Central Time. We've got over 400 folks registered for this webinar today. It's planned to go for about 90 minutes. We're going to try to hopefully keep everything running smoothly. We've also have the webinar. It's being live broadcast on Facebook, as well as we'll be posting it on YouTube shortly this weekend. To go ahead and get started, my name is Bill Cantrell. I am a registered nurse. I've been on both sides of the bed, as far as I've been the patient as well as I've been the caregiver. Being the patient most recently really opened my eyes to a lot of things, and I've become fairly outspoken on ICU care and things that we can do better to improve it. I look back over the years and based on just the healthcare profession not understanding, some of the things that's going on, we've kind of measured it as, at the end of the day, the success is, well, the patient lived. And there's really, it's a lot more nuanced than that. Luckily for me, my background has been one that I've had a very broad background as far as everything from a paramedic to a flight nurse to cardiac electrophysiology. Unfortunately, the nursing field is awesome in that you can reinvent yourself, you can do different things. A lot of the areas of care that touched me were also ones that I had worked within. It's really a case of sometimes having too much knowledge can be a double-edged sword. Some of the things that got me there to the intensive care unit is a bad heart. Patients are going to get to the ICU and delirium. There's lots of different roads to get there, but there is some commonality in how we can manage those patients and treat them. I had a couple of open heart surgeries 4 years apart. The first one was a breeze, kind of ran through it. The second one was they had a hard time weaning me off bypass. I was on the balloon pump, lots of pressors. This is one of the things afterwards. This is how much they had clamped me down with pressors. This is the toes a couple of days after discharge. On the left is right at discharge. And so lots of wound, skin care, everything just to get those back. I'll probably never be a foot model anywhere, but at least still have all my toes and everything still works. The thing that after the open heart surgery that got me in is that went in for a routine ablation. It was supposed to be, I was having a rapid heartbeat. This was about 60 days after the second open heart surgery. I really hadn't recovered from the open heart surgery, and they wanted to go in and do ablation so that they could cut out some of this activity that my heart was doing, as well as get it where I could go through cardiac rehab. This is my EKG. This is a home EKG on the left, and this is the EKG when they brought me into the prep area for the cardiac electrophysiology. It's really, those wide complexes aren't supposed to be that way. They're supposed to be nice and narrow. And so I'd been in and out of VTAC over the days and weeks leading up to going in for the ablation. When they got me in, the nightmare kind of for me started at that point. In the cardiac electrophysiology lab, I spent I believe it's around 5 hours in there. I got shocked somewhere around 16 times. All of those were fully awake, no real sedation because my blood pressure was so low. They finally intubated me, sedated me. They did as much as they could, and they took me out to ICU. Over the next few days there, I was keep going into the rhythm, having to be shocked, getting shocked 5 or 6 times a day with this. Every time my wife was at bedside, she had no idea, whether this was going to be the last time that I was going to be shocked and this was going to be over, or if I was going to bounce back. I ended up originally started off at the hospital, Southwest Washington Medical Center in Vancouver, Washington. I got really too sick for them, and they ended up flying me to hospital over in Portland, Oregon, about 10 miles away, Oregon Health Sciences University. This is me in CVICU on December 9th, 2020. I'd went in for the ablation on December 4th and had been there. So I'm pretty much on just about everything. COVID was raging at this time. It was still, the hospitals were starting to tighten down. There was a lot of worry and fear in the air. So I'm basically hooked up to everything. I was the kind of patient that I loved to take care of when I was working as a nurse, just having all the technology, the different items there that were working to keep me alive. They were doing everything possible to break the rhythm, but every time they turned me, I'd have to get shocked again. This whole time, I pretty much lost the entire month of December for the most part. You kind of wonder when patients, I've told folks that, my wife had the hard job. She was at the bedside. I slept through it. I guess sleep is not really a good term for it. I wouldn't really characterize it. It was more than a black hole. During this time that I was presented with hallucinations, vivid dreams, there would be times when I would be in a loop, feeling like I needed to accomplish something before ending up, and it would just repeat. Or I would be in a case where, flashbacks or memories. I would be in situations where bits and pieces, my brain was kind of putting things together in the background. Even though they were doing sedation vacations in the mornings, I really have no memory until the end of the month when they finally extubated me. A lot of the things, some of the dreams were just, your routine, typical type of dreams. Others were not so nice as far as really more so of being nightmares. And these continued. I had no real sense of time, had no real sense of where I was at. It was just a loop with darkness in between. One of the worst ones that I had was one where I was playing on a beach. And the beach, this is obviously not me, but on a beach has always been my happy spot. So I'm laying on the beach, the waves are coming in. And then this dream kind of takes a dark turn. Everything starts going dark. The water starts rushing up around me. I ended up going through and I felt like, I was drowning. It was a very real sensation to me. I was gurgling. The lights would go to dark and then it would start over. This happened multiple times. I've thought about it since being discharged, and I don't know. I mean, it could have been anything from, nothing was going on in the room. Maybe respiratory was suctioning me and irrigating with saline. It's hard to say. And again, this happened over and pretty much over and all the way to fading to really black. So it's one of those things that was a nightmare that you just really couldn't wake up. This is me in the ICU. This is on Christmas Eve. This was at Oregon Health Sciences. They were lightening up the sedation. This was really the first time that I had any memory. It was like I was coming out of a deep, dark hole, and I could hear voices, and there were bright lights. I ended up, prior to this, they had been kind of waking me up a little bit and asking me, move your hands, move your feet. And I cooperated for a period of time, but I kind of got, my wife can tell you, a little bit obstinate. And I said, I'm not doing this. Why should I do this? I've got I've got dreams to take care of. So I quit responding when they did the moves and everything, wanted me to do it. So that ended up buying me a head CT to make sure nothing was gone wrong with the brain. So it's a little bit of one of the interesting points. They had planned on that they were going to try to extubate me. If they weren't successful, I would probably end up with a trach. This is me right after. You can see the little Christmas trees on the EKG. I still had the defibrillator pads, which were kind of a constant accessory. This was on Christmas Eve day. That night, about 2:15 in the morning, Life Flight picked me up and it took a jet to Stanford Hospital for a possible heart transplant. They had done as much as they could. That was one of the few hospitals that would accept me. I was so sick at that point. When I arrived at the facility there, I was just awake enough that I still had a lot of delusions, a lot of confusion. I thought that I'd been in a Mexican hospital being taken care of by nurses who were nuns. And that's kind of, it was kind of an interesting thing as I was sounded totally lucid and telling them this as they started digging through the charts, seeing how they had missed this in report. One other thing that I got from my 20 or so days intubated on the ventilator, they hadn't been able to turn me. So this is on the left is the butt cheeks, my butt cheeks after arrival there. It was already an open weeping area. On the right is a few days later with eschar. So this was kind of adding insult to injury with all this. And so we'll come back to this towards the end again as this continued to progress. This is me at the end of the first week. I was still very confused, sleep deprived. Because I'd been, on the ventilator, unconscious, asleep, supposedly for the last 20 days or so, it's not a very restful sleep, if any. I was really depressed on the one on the second week on the right, was really putting on a good face. This was one of the few ways that I could communicate with my wife. She had to stay home. COVID was still raging. They had told her, you can come to Stanford, but you won't be able to get in to see him. So she stayed behind and kind of managed things from afar. This whole time, the drugs were really slow. I really couldn't sleep. I went for several days without sleeping or just very sporadic sleep. I ended up really just was afraid to sleep. A lot of times, if they laid me flat or anything, I was afraid I was going to die in my sleep. Worsening depression. It really felt like this. It felt like the nursing staff were great at Stanford. However, this was a year during COVID, so there wasn't a lot of interaction. I mean, the rounds sometimes would occur with the physicians almost at the doorway, with maybe only one physician coming in the room just to reduce their risk. It really got me down in a pretty dark hole as far as being confused, not really understanding, being in pain away from home. I thought for ever so long that my wife had turned me into a do not resuscitate. I thought that one of the night nurses was probably going to try to kill me. So it's definitely, from a patient's perspective, I mean, I've taken care of those patients in the past. Definitely wasn't the easiest way to go. I had finally decided it got so bad. I mean, I would be talking to people that weren't there. I'd be having a conversation and look, no one's there. I thought for ever so long that I was back in my hometown of Greenville, South Carolina, at one of the hospitals there. So really took a long time for the medications and everything to clear on me. And I was still down in a dark, deep hole. So I finally decided that I was kind of tired of it. The pain and everything else was it was a case where I was done with it. I couldn't know what was right or what was real and what wasn't. Was still having, lots of medical issues, pain. I finally decided that I was doing an inventory and I was kind of looking at, what do I have to be grateful for? I was doing a little self-pity party for myself at that point. And really was looking and, the only things I really had to be happy about or be thankful for was, well, I'd survived. That's kind of maybe a good or a bad. There was one medicine that they gave me twice a day. I think it was for my stomach that tasted like watermelon that dissolved. So I kind of save it for last. There was also ice chips. I still couldn't feed myself or anything. I was so deconditioned. When I got to Stanford, I couldn't even lift my head off the bed or couldn't even feed myself or hold it. I developed a really nasty tremor. So I was kind of in a mess. And so I decided I still had a left brachial art line that they'd put in. They were going to change it the next day. It was real positional. And I'm sitting there and I'm thinking about what I'm going to do. I've decided, well, let's see, maybe this is all a dream. It's another hallucination. I decided that I would just go ahead and open up the stopcock that night. It was on the side that was away from the door. I figured that my hemoglobin hematocrit was low enough that I could probably bleed out pretty quickly. They hadn't been too attentive to the heart line because the waveform, it was very positional. But I figured that I could, at least this would, answer one question, was it real or not? And this would get me out of some of the deep hole. And I sit there and I started going through and really thinking about, what's going to be the impact of this? They're finishing up my care. I'm waiting. They're doing all the nighttime stuff with the nursing assistant and the nurse. They're in there changing dressings and things. And I'm just waiting them out. I knew as soon as they left the room, they were probably going on break, which would give me some time to finish the deed. And as I'm sitting there and I'm thinking about it, I started thinking, I got out of my own little selfishness and started thinking about, things like my wife. This was going to totally devastate her. And that was really, the thing that pulled me back from the edge to keep me from, ending up someplace where I really didn't want to be. I was still extremely confused, delusions, paranoia. Night times were the worst for me. Still wasn't sleeping a lot. Lots of really interrupted sleep. If any time that they laid me flat, my SATs would drop down into the 80s. I kind of always felt like I was smothering. I ended up one morning, it seems like this always happened in the morning time, I ended up almost getting intubated. And I'd been through this process as a nurse many times. The SATs were dropping, people were looking at each other concerned, the non-rebreather mask was in place, and all of a sudden we're waiting because the BiPAP machine was right at bedside. My lungs were filling up, the heart was backing up. And I've set up that machine hundreds of times and, I just didn't have the energy, couldn't get to it. The nurse was there, the physicians came, again, more concerned looks. And then it started the whole process of, crash carts in the room, intubation carts in the room, beds pulled away from the wall, the headboard comes off, and this terrified me. And finally, just probably minutes before they were going to have to intubate me, respiratory had been shift changed. They had traumas coming in. Respiratory got there and got me set up on the BiPAP. But it was the closest. It was terrifying for me from a medical perspective. This is me from late January. I'm still in Stanford, a little bit better on my spirits as far as I continue to progress. We were still chatting back and forth with my wife on Zoom. That was really, we were doing it several times a day. I still was having problems. I could lift my head, but I was having difficulty still feeding myself. Physical therapy had started working with me at that time and started going through the process of trying to get me. I started out not even being able to. They were lifting me out with the lifts. I was definitely not able to do a lot to assist them on that. And then they started with some training with a walker. And it was really just kind of starting over from the whole process of walking. They finally got me. Another thing that seemed to always happen was there were things that kept happening and the goalpost kept getting moved for me going home. I would pretty much every day was calling my wife and we were talking. I'm crying on the phone, begging her to come, pick me up. And, even very unrealistic. I even called and had her talk to a friend of mine who's an electrophysiologist to see if they'd take me back, if they could manage me. I was at one point asking her to get a van and just come down and, take me home. I was ready to go. Finally, I got another jet ride back to Portland, Oregon. I was going back into acute rehab. I must have some pretty significant life flight miles between a helicopter ride to OHSU, a Learjet ride to Stanford, and then a Learjet ride back to get to acute inpatient rehab. Again, COVID, I saw my wife for probably about 10 minutes at most, just as they were taking me out of the ambulance to take me to acute rehab. Again, COVID was still, just raging. This was my room. This was my view. My wife would come out to the front parking lot on the drive there, and I would be in the window. When I got to acute rehab, I got technology. When I went to Stanford, I had nothing but a hospital gown. I had no reading glasses, no cell phone, no iPad, none of those things. So I was kind of lost until that. And here I'd flash the flashlight on my cell phone so she could see which window I was in, and then we would, have a chat. I spent about a week there in the acute inpatient rehab. Finally ended up coming home. This whole thing had started December 4th, and so it was roughly about 2 months that finally home. The neighbors had really went all out as far as welcoming me. I'm sure most of them thought that, I'd never be coming home again. So it was kind of a nice positive thing. This is me. I was barely able to walk. I'm still on the walker. Finally home. This was rough as far as walking up the steps. I mean, nobody wants to triumphantly come home and scooch up the steps on their butt. So I at least was able to make it. I was on a walker for another several weeks from there. The thing about it, finally, the storm was over. Like all storms, when they end, there's the aftermath. Sometimes, people live, sometimes people die. There's a lot of collateral damage. It very seldom affects just a single individual. A lot of times, the injuries and the damage is done multiple individuals. And, just because I went through it, a lot of the attention was on me. But in reality, my wife had just as hard, if not harder, road in this as she went through, being at the bedside, for this entire time. So it really was a wake-up call for me. Revisiting the decubitus ulcers, this is what they look like on discharge when I came home. The top one on the right side is a stage 4. It was just ground beef, hamburger meat type. And this took months for me to recover from, going to the wound clinic several times a week, then weekly, until everything's finally closed up. I don't think I'll ever be a model for my rear end on OnlyFans, but at least, things are pretty much back to near normal right now and no further issues with that. One of the things that was probably the most valuable to me during this time is I had a huge hole in my memory. At least a month was gone. And my wife, we had talked about, and she had started keeping a diary. And I still go back through and read it a couple of times a month sometimes, just to go back through. And it just reminds me of the things that I've got to be thankful for. And this was one of the best tools for me to be able to see what had happened. She is also in the medical field, a physical therapist, so she put a lot of medical details in there. She knew I'd be interested. And so this is, it's when you read through and, you're seeing things like, well, they don't think he's going to make it through the night kind of things. It really brings it home. It's like, gosh, they were talking about me. So it's a pretty significant point for me. Now, this was me last year at the Emergency Nursing Association teaching advanced airway management in the experience hall. We're going to be going back, and this was about the time that this was about 3 years when I was there, that really, from the time it took me that amount of time just to be able to talk about this. I didn't want it to be something that defined me. I didn't want to be that, critically ill patient that, barely survived. And so I really didn't talk about it that much. And I really didn't share a lot of the details. It kind of is unraveled or unrolled over the time. It was this time when I was back in San Diego at the ENA that I decided that I was going to put this down to paper. I was going to start talking about my experiences and become very active in trying to make sure other people don't go through the same experience. So that's kind of helped. And it's actually this year I'm going to be presenting a similar presentation at the ENA coming up next week. Some of the things that I picked up from the storm, the importance of family. It really, I didn't realize how the isolation and everything would affect me. I hadn't really, in the past, I had taken care of the equipment, and hopefully saved the person's life and then sent them on to their next, place in the hospital. And this really brought it home to me that, being away from family, being isolated, minimal contact, that's a big reason that people, for a period of time there, I lost my why. Why to keep moving forward, why to put one foot in front of the other, why to continue living. Really impressed upon me the difference between gratitude and thankfulness. Gratitude is just an ongoing feeling, whereas thankfulness can be sometimes transactional. I've learned that, and I try to make sure that I'm, both have gratitude and I'm thankful. I mean, in the hospital, I was dependent upon other people to do everything for me. The impact of critical illness, the deconditioning that I went through, the weight loss and everything was significant. The mental toll, just because I wasn't in a delirium state anymore, doesn't mean that I don't still have the scars from that, just like the physical scars that I have from this, hospitalization. Took a huge toll on me mentally. I've noticed that after everything that, was pre this critical illness, the depression is worse. The attention deficit is worse. I've got where I had fairly well controlled emotions. I do have a huge fluctuation between highs and lows at this point. And I recognize that, and it's something that I need to continue to manage. The value of having a team, having people around you. I mean, I think that if my wife hadn't been there's a good chance at some point or the other, I would have decided that, this maybe is not working, or pull the plug, things like that. So that was really, having a team. And during this whole time, I mean, my team with Recess Med kept the business running. I mean, I was going in initially in December, for what I thought was going to be, I'll be out that afternoon, or maybe at worst the next morning. So 2 months later, I get back home. So they really kept it going, and also helped support my wife. I mean, luckily she had good support systems of neighbors, friends, family that really helped ease some of this. One thing that I did recognize was a significant issue is there was really no post-discharge resources. It's kind of like you go through this trauma and, hey, you lived, but what happens next? You see your primary care, you see some specialists, but there's nobody really addressing some of the ongoing issues, both the physical, mental, and emotional. And so that's an area where we really have a lot of opportunities. I guess in closing, for my portion, before we move to Wes, is really the fact that this is something, whether you're a family member, that you need to be really engaged with the patient's care. You need to be their advocate, and you need to make sure that those patients are getting the type of care that they need. Nobody in healthcare is doing the wrong thing, or no one is going out and, making this happen. It's more a case of its lack of knowledge. So this is an area, and that's one of the reasons that kind of brought me to pull this group of folks together and to do this webinar. We'll be doing some questions at the end. If you want to take a real quick 5-minute break, I'm going to get Dr. Ely set up real quick, and give me just a second, and we will get this going. About 5-minute break at most. Dr. Ely, I've made you the co-host, so you should be able to share your screen and put your PowerPoints up.
Thank you, Bill. And tell me the how much time I have.
How about as much as you want? We planned on about 30 minutes, but
And
it's
Kaylee's going to go after me, right?
correct.
And what's the end time of our time here?
We were planning in about another hour. So you've got as much time as you need. I mean, I'm sure that if folks, you need to go over a little bit, that shouldn't be a problem.
I want to make sure I'm respectful. And everybody's hearing us right now, right?
Correct.
Yeah, that's fine. I wanted to make sure that we were respectful of people's time and that we also have time for opening up for talk, for questions. I want the audience to feel comfortable talking to us, unmuting and sharing. I think that would be the richest time besides your story, which was extremely moving. So I'm ready to go whenever you are.
You should have the co-host control, so you should be able to share your screen and PowerPoint or whatever other materials you have.
Okay, let me just have a moment here to get my thoughts together.
If there's anyone also that has questions, I'm going to be monitoring chat as well as Kaylee. So if you have any comments or anything, feel free to put those in the chat, and we will have a question and answer period at the end.
Okay, Bill, I'm ready to go whenever you are, and I know there's a lot of people here, so I want to be respectful of their time.
And are you able to share your screen?
I'm just going to talk.
Okay.
Tell me you're ready. Friends, thank you so much. Now, are you sharing your screen right now, Bill, or because I see you on there? I don't see the whole audience. I see you sharing. Can you unshare? Bill?
Working on it right now.
Okay.
Okay, I'm unshared.
Okay. Tell me, why don't somebody let me know if y'all are seeing the whole gallery? I think we are. Somebody give me a thumb up if you're seeing the whole gallery, or okay, just me. Okay. Look, my name is Wes Ely. It's a privilege to be with you today. There's about 150 people on this call right now, and I am really moved by what you just shared, Bill. That was an extremely intense story, and unfortunately, it's all too common. When people enter into their world of critical care and they go through utter hell to try to get to the other side, to try to get to that place where you are walking up those stairs to come home with those open wounds on your buttocks, which you showed us. I found you being extremely vulnerable to share all of that personal story with us, Bill. And I want to be, first off, just respond a little bit as a physician to what you shared. I never want to live again in a place at the bedside with my patients where what I'm doing with you is a transaction. And you brought up the word transactional. And what I think we have to recognize is that we are immersed in the humanity of human suffering in the hospital and after the hospital when people like you, Bill, and so many others who are on this call today are going through their own recovery process and suffering. Instead of transactions, which is a contract, what's happening for us is that we must instead enter into a covenant, not a contract, which is a transaction, but a covenant, which is a promise. And the promise is that we will love each other in a way that looks and finds and sees an entire person there on the other side of our interaction, of the bed, of the rehab center, of the stairs on the way up into the living room to get home, whatever that experience is, that we will dive all the way in to that chaos. And what we can do if we are willing to enter into that promise, that covenant, is we open ourselves up to an immense amount of goodness and love as people as we go through this life experience, witnessing to other people suffering and becoming a part of their illness and their recovery. And so as an ICU doctor here at Vanderbilt University, to me, I can never earn the privilege of being with you all during these experiences. And whatever it is that you've gone through and you would like to share with us later, then let's do that. Kaylee, after I go and Kaylee goes, we're going to open this up now to talk and have you share with us. The second thing I wanted to say is that no doubt there's a benefit and a cost to this promise, this covenant relationship that I'm talking about establishing with one another. Here at the CIBS Center, for example, we are part of a program called the CIBS Center, CIBS, which is critical illness, brain dysfunction, and survivorship. And here at our center, our research center here at Vanderbilt, we have a science side where we try and do clinical trials and studies and find you answers. And we have a humanism side where we try and join together with the science to open up support groups and have a social worker who can work with you when you're trying to find disability, housing, a new job, those sorts of things. Just this week, on Monday, I went out to a former patient's. I had an ICU patient. I won't mention her name, but she does give me permission to share her story. I drove out to her house. We got her. We brought her here. She's out of the ICU for over a year. She texted me and said, Dr. Wes, Dr. Ely, I don't know what I'm going to do. I'm about to get kicked out of my condo. I can't work anymore. I can't use my hands. So I lost my job. I can't make money. And what's going to happen to me? And so the social worker here dove into her chaos and is trying to help her find that next disability approval, that job that she can do. We got her bypassed her insurance company, which was out of network, and got her seen by an autonomic specialist so that she could get some medical care this week. These are the things that we all will do for one another if we dive into this covenant relationship. And the benefits are obvious, that we get to know that as human beings, we are entering into what really matters. The beauty and the simplicity of what really matters, which at the end of the day is loving one another better. And the cost, though, as you were talking about this, I was thinking about because you also are a healthcare professional, and you said your interactions had become transactional with your patients. The cost is the possibility of emptying ourselves so much that we're left bereft of balance. And so I don't want to ignore that. As a doctor myself, I have to work very, very hard. People ask me, Wes, are you a glass half empty or a glass half full? Neither. I am refillable. I'm refillable. And through reading and meditating and praying and exercising and talking to, I have a sponsor. I'm in Al-Anon. I have a spiritual director who's a priest. Through talking to all these people and working on my own relationships, I get refilled, and that allows me to be able to be present, Bill, for the patients that I have who are suffering the way you have. Now, as you were talking, I didn't plan on this, but I think I'm going to read three short paragraphs out of this book. This book is called Every Deep Drawn Breath, EDDB. And I'm going to read through three paragraphs out of here because what you said, these are all real people, real stories. I recorded all their stories with the device like this and transcribed them, have all these patients' amazing stories back here in drawers. And the purpose of this book was to try and provide people who are suffering with post-intensive care syndrome help. And that we used the money from the book to hire that social worker I just told you about that we worked with my patient. Anyway, I'm going to talk about in-the-moment experiences of a few patients. Then I'm going to shift to a story of somebody who, what they were living through after they get out of the ICU. And then I'm going to read to you the story of a musician and what he experienced afterwards. And I saw his name on the list, so I know he's with us today. I would have read this story anyway. It's an amazing story. Sometimes the dreams come back, said Sarah quietly. Just out of the blue, she paused, thinking. Several people were nodding in the support group. We've been talking about burnout, the exhaustion of living with ongoing critical illness and being defined by it. It's disquieting because you think they've gone away and your life is normal again. But then they return, remind you that it's not, continued Sarah Beth. It's as if no matter how far in the past your illness was, you can't get away from it. You're right. It all came back to me again yesterday in the middle of the day, Kyle blurted out. He grabbed his wife's hand. Our daughter Harper was home having a pajama day with us, and there I was with the Jaguar. It was so real, I could feel the terror. And then he goes on to describe it all day long above his monitor. He says, my hands were restrained, so I couldn't even defend myself. That went on for about a full day, and everyone I was looking at thought I was looking at the monitor, and that was upsetting because I was thinking, I'm not the crazy here. You guys don't see this thing? That was his delirium, his experience of going through this, okay? Then I skip a couple of pages and I read to you over here. The delirium stories flooded in. There were so many of them. One survivor on the Zoom screen, now we'd moved to Zoom, a different type of support group, had dreamed, get this, had dreamed he'd been jailed for 5 years and his wife had died. The experience was so real for him that it took 2 years after surviving and getting out in the ICU to realize this wasn't true, even though his wife was right there with him day in, day out, clearly not dead. You've taught me so much. And the last story, Steve Edmondson and Lamar Hill, regulars at our support group meetings, are both former professional musicians who survived sepsis, only to find that they no longer even wanted to listen to music, much less play their instruments. Steve was a jazz and blues guitarist with the Dynatones in the 90s, and then with the Jackie Payne's Steve Edmondson Band from 2001 until his ICU admission in 2010. After his discharge, he told his wife, Judy, I woke up a different person, one I don't particularly like. A key part of him had disappeared, but for years, his doctors told him there was nothing wrong and nothing to be done. The reason I chose to read those stories to you is that for many years as a doctor, I thought that my job was to put in that central line, to put that chest tube in, to get my patient intubated. These are transactions. These are procedures. And I became very good at those procedures. And before I had all this gray hair, I thought, oh, I've arrived. This is my job. This is what I do. And then one day, a woman, a mother, a young mother, came back into my clinic, and she looked at me and waved her finger and said, you didn't do your job. And I was convicted. And she said, I can't take care of my kids now because I messed up. I've got muscle and nerve disease and I can't think clearly. And I'm 34. And then many, many more patients started teaching me what they had gone through and what they were experiencing. And I sat with them and I thought to myself, Wes, you aren't doing your job. Another friend of mine named Carol Billion was sitting right here in my office. We were talking about her experience. And after hearing her whole story of going through the ICU, at the end, I said to her, what do you need me to know that I don't know? And she said, well, have I told you how I went through rehab, how I fixed myself? And I said, no, tell me what you're talking about. I was still recording her story. She said, well, when I got out of the ICU, I couldn't even start my computer, couldn't start my laptop. And I started a brain retraining game for me. I started doing word games and math 30 minutes at a time for 3 months, and I rebuilt my brain power. Another man who was a farmer, a tractor, could not get in and out of his tractor anymore, and that was his livelihood. So he had to go through body rehab. And these people who were teaching me, Carol Billion, you Bill today, Kyle Mullican, Sarah Beth Miller, all of them teaching me never give up hope. Never give up hope. Because hope, and you could use the acronym, hang on, pain ends. Or hold on, peace exists. That even though we can never get rid of the suffering, what we can find on our bookshelf is that when we get out of the ICU, there's that one book of suffering, but over time, even though the suffering never goes completely away, other books can appear. Books of gratitude, books of hope, books of love, books of thank you for being present with me and being part of a community. We need community. My brother is a big tennis player and I'm a swimmer. And I love when I go swimming for an hour, hour and a half, 2 hours, just meditation, prayer, getting my thoughts together. I tell my wife, Kim, I say, honey, you know I need to get in that pool to be the best husband I can be for you because I'm insane if I don't have some time like that. My brother, though, told me, he said, Wes, tennis, this comes back to the ICU community. He says, tennis is actually perhaps even better than swimming because it has community around it. When you're in the pool, you're by yourself. I thought about that a lot. I have a lot of addiction around me in my life, so I go to Al-Anon. I said, Scott, Al-Anon is my community. That's my tennis. So I swim, I meditate, I pray, but then I have these groups of people who listen to one another. We don't judge each other. We can complain and cry and also enjoy moments of gratitude with one another, even though we know that we've been through very, very difficult things. And that's the way I view you all. You have been through something that I will never fully understand. Yes, I'm your doctor. I can be the doctor at the bedside, but I'm not going through it myself, so I cannot fully understand what you're going through. But I can try and keep in the forefront of my mind that my goal is mercy. And my working definition of mercy is to dive into your chaos and provide lifting and healing. And so what I think we have learned over these last 15, 20 years of doing this work is that the healing, the lifting and the healing comes through us listening to you, you teaching me, what are you suffering with? What are you going through now in this recovery? And then creating a community around you so that you can share, scream, cry, find answers, find disability insurance, find a rehab program, find whatever it is that you need to get to tomorrow. And the last thing I'll say, and then I'm going to stop talking and we'll go to Kaylee, is that what I've learned is that I spent too much of my life in either the past or the future. I was either worrying about what happened in the past, and Bill, we cannot erase that horrible thing you went through. I don't know why you had to go through it. I don't know if or what anything about it, but I know it's in the past, and I know we can't control the future. But what we can do extremely beautifully, Bill, is what you did today for us. You brought us into the present moment of your life. You shared with us where you are today in your life and how you're giving back to help other people learn so that they can either process what they went through and know where they are in this moment and then try and find a way forward, but only through the moment, because we have to stay in the present moment. It's the only time we have access to. And so thank you for that gift to me. You're helping me become a better physician. And I just appreciate all of you, your time today. I'm going to stop talking. I'm here to listen again. Kaylee, let's switch over to you. Let's learn from you. Everyone, Kaylee Dayton is a first-generation prodigy of Polly Bailey. In EDDB, in Every Deep Drawn Breath, there is the story of Polly Bailey. If you get this book, look up Polly Bailey and read her story. She was the first genius nurse at the bedside in Utah that realized that the doctors were wrong. And she looked and wagged her finger at Terry Clemens, a very famous physician, and said, you are wrong, and we've got to do this better. And then she trained Kaylee, and you're lucky to have Kaylee with you today. Kaylee, teach us what you know and help us learn.
That was quite the intro. I hope this isn't anticlimactic, but thank you so much, Dr. Ely, and thank you, Bill. I too have relied heavily on survivors to teach me what critical care medicine is really about. And I want to add on to what has already been shared and shift it a little bit to what do we do about it? We recognize now from much of Dr. Ely's research and many researchers, as well as survivors that have shared, that what happens in the ICU can greatly determine not just whether or not a patient survives the ICU, but what kind of life they live after the ICU. So let's talk about what can we do to preserve quality of life, to give patients the best chance to not only survive, but to thrive as well. So as Dr. Ely mentioned, I come from an awake and walking ICU where almost every patient that was in the ICU, especially if they were intubated, they were awake and doing their highest level of mobility, oftentimes walking. This patient was a COVID patient, hanging out playing the guitar, and that wasn't an unfamiliar scene in our COVID ICU. And the reason this is so important is because what Bill has described, this post-ICU syndrome, the physical, cognitive, and psychological impairments that survivors suffer long after the ICU is usually rooted primarily in delirium and ICU-acquired weakness. Delirium is an acute brain injury. ICU-acquired weakness is a muscle failure, muscular damage and atrophy. And in the ICU, a lot of that oftentimes comes from sedation, so medically induced comas, and immobility, being unable to even, contract a muscle while sedated, while in these comas, while sick in these hospital beds. So now we're going to shift to what do we do about it? We know that sedation and immobility lead to delirium and ICU-acquired weakness, which leads to long-term impairments, disability, suffering, PTSD, cognitive impairments, physical disabilities. What do we do about it? Obviously, we need to provide support for all ICU survivors, but there's a lot we can do early on in an ICU stay that will give patients the best chance to go back to their normal lives. And that is the ABCDF bundle. And that's how our patients are going to walk home from the ICU or have the best chance to do so. So again, I come from Polly Bailey. I am her prodigy, I guess is what Dr. Ely is saying. She is my mentor, my hero. She really questioned the status quo, even back in the 90s before there was ever any research. And so she really founded this approach to care called an awake and walking ICU, which is defined by an ICU that only gives sedation when there is an indication for sedation. So patients are not automatically started on sedatives right after intubation. When there is an indication for sedation, such as seizures, intracranial hypertension, the inability to oxygenate with movement. In Bill's case, it was the inability to even turn without having his heart fail. So in those kind of cases, the safest sedative is given at the lowest dose for the shortest duration possible. And patients are doing their highest level of mobility unless there's a contraindication to mobility. And there's open family visitation. Families are a key part of the ICU team and not kicked out in the evenings. So this is what many patients can look like, even during their critical illness, even during mechanical ventilation. And so how do we create that? And so that's where Dr. Ely and many other founders developed the ABCDF bundle after seeing what Polly Bailey was doing in her ICU. They put together these tools to guide us to keep patients as awake, communicative, autonomous, and mobile as possible. So many of you probably know what the ABCDF bundle is. This is something that was rolled out in the 2010s, but it's been a little bit misunderstood or misconstrued along the way. It's really important to assess and prevent and manage patients' pain, to keep them awake unless there's a contraindication to mobility, breathing, choosing the safest sedative, or whether or not to sedate patients, managing their pain, assessing and preventing their delirium, keeping them as mobile as possible, and having family engagement. So this is a toolbox with, again, a bunch of tools, and this can seem overwhelming. It can seem like a lot. And this has become kind of a checklist in the critical care community. But it's key to understand the objective, why the ABCDF bundle exists. And it exists, to quote the SCCM ICU Liberation campaign, it says the goal is to produce patients who are more awake, cognitively engaged, and physically active to facilitate patient autonomy and the ability to express unmet physical, emotional, and spiritual needs. This is not just a light switch every day to turn sedation off and on. It's not just to chart certain things. It is to see the human in the bed and treat them, treat the critical illness without causing further long-term damage, to really humanize our patients. So I try to, when I train teams, I say that they need to memorize and deeply internalize these 4 words: awake, communicative, autonomous, and mobile. And when we really strive to do that for every patient possible, this is how many patients can look during their critical illness. And so let's talk about what this actually looks like. Let's apply this to real patients. Luke was a patient that I've treated before. He was a 22-year-old with trisomy 21 and autism. At baseline, he had the cognitive function level of a 3 to 4-year-old. He was admitted for mycoplasma pneumonia and mild ARDS. Shortly after intubation, he was on a PEEP of 12 and FiO2 of 80%. I don't want to overwhelm those that don't work in the ICU, but just understand that Luke was very sick. And we had a lot of concerns as far as how are we going to keep Luke safe? How are we going to keep the endotracheal tube in him? He is not going to understand the ICU. He is likely to pull that out. So there are a lot of things that we have to consider during critical illness, but we also had to zoom out and say, how do we keep Luke safe from delirium and ICU-acquired weakness? If we allow Luke to develop delirium, especially, we would never want to cause Luke delirium, but sedation was going to substantially increase his risks of developing delirium. And that would likely cause a long-term brain injury. And so with a baseline functional level of a 3 to 4-year-old, if he had a brain injury, would he lose the ability to care for himself, to dress himself, feed himself, toilet himself? That would change his life substantially forever. Could he end up with trauma, post-ICU PTSD? Would he lose the ability to walk? And so we asked this question that Dr. Ely asks, what can we do for Luke, not to him? And that's what inspired us to really look at the risk versus benefits. Yes, he may not understand what's going on. He may try to pull out his endotracheal tube. But if we don't mobilize him, if we don't keep him awake and moving, he's at far greater risk of dying, of ending up with a tracheostomy and PEG tube, being on the ventilator for longer, a ventilator-associated pneumonia, hospital-acquired infections, falls, delirium, length of stay, post-ICU syndrome. We had to consider Luke's safety in the long run as well as the short term. Keeping him awake and mobile is going to increase his risks, his likelihood of being alive in a week by over 68%. So that's the course of action that this team took, as they allowed him to wake up and allowed him to interact with his family, hold their hands, make eye contact. We kept him loosely restrained just as a reminder. But as long as he had his music, his cartoons, his toys, his eye, he sleeps in a tent at home because of his autism. So they built him a tent over his bed to help him sleep at night. They really were able to humanize and customize all this care to make it customized and personalized for Luke, for who he is, not just a sick body in the bed, but for a wonderful human being that has quirks and nuances and so much value to add to his family and to the care team as well. He was really quite fun to take care of. He liked to cross his legs at baseline, and he would rock back and forward when he was stressed, when he was anxious. So he was allowed to do that even while intubated. Here he has his legs crossed. He was rocked back and forward. And we allowed him to continue to do those things that he needed to cope with his situation. And he did really well. Here's him walking. The biggest risk was that he was a fast walker. He also liked to sit down and cross his legs on the floor. That's what he did as baseline. So he was allowed to do that while on the ventilator. Everyone would just stop, take a pause. And when he was ready to go, he'd stand back up and keep walking. This is how we keep him safe from falls, self-extubation, ICU-acquired weakness, delirium, all the risks. This is what safety in the ICU needs to look like. And so after 11 days of being intubated, he was successfully extubated. He likely had some baseline dysphagia, so he did go home with a feeding tube, but he discharged home. And a week later, the feeding tube was out, and his mother reported to me that he was back being his loving, affectionate, playful self back at home. He had a true restoration of his life as a whole. Now let's look at a contrasting example. This is from another hospital with a normal ICU culture. I would say just a failure to really master the ABCDF bundle in this way. And let's look at how we set patients up to develop post-ICU syndrome. So Diane is a 54-year-old female with a history of methamphetamine abuse. She lives with friends in a trailer park and works as a marijuana washer. She has a son that lives an hour away from her. She arrived to the ED on the evening of June 17th with shortness of breath and hypoxia. She requested to be intubated, and following intubation, she was on 90% in a PEEP of 10, so she was on a lot of support from the ventilator. She was admitted to the ICU for acute respiratory failure, secondary to multifocal pneumonia, septic shock, and AKI. Her toxicology screen was positive for amphetamines and THC. So she had pretty severe pneumonia. The team had lots of concerns considering her drug abuse, things like that. But what should have been asked in that moment, after intubation or at least upon arrival to the ICU, they should have stopped and looked at, how do we keep her awake, communicative, autonomous, and mobile? They should have asked, does she have an indication for sedation? What are the risks versus benefits of sedation for her? What are her risk factors for delirium? What are her risk factors for ICU-acquired weakness? A few days, weeks, months. How will our choices today affect the rest of her life? What is the safest, most effective, and cost-efficient way to care for Diane? Who is Diane as a person? Not just as a diagnosis, not just as someone with a drug history. We put all sorts of labels on patients and project a lot of things into them that impact how they're cared for. Instead, we should say, who is she as a mother? Who is she as a friend? What does she need to stay awake, communicative, autonomous, and mobile so that she can survive and thrive? So day one, she's intubated, sent to the ICU. She's on propofol, fentanyl, vasopressors. Day two, now her ventilator settings are going down. Her pneumonia is looking better. She has she's on FiO2 50%, PEEP of 8. She's still sedated. Her vasopressors are almost off, but now she's getting benzodiazepine pushes, more sedation. And she has a documented RASS of -2. And I put those in quotation marks because that RASS reflects that she is able to open her eyes to voice, make eye contact for less than 10 seconds. And yet at the same time, when I look at her vital signs, she was taking the same amount of breaths on the ventilator as she wasn't taking any independent breaths on the beyond what the ventilator was giving her, meaning she was so sedated, she wasn't even trying to breathe on her own. And there was no awakening trial, no breathing trial, no screening for delirium, no early mobility done. Day 3, now she's on very minimal ventilator settings. She's probably ready to be extubated. Her pneumonia is probably better, and she should be able to independently breathe. And yet she's still sedated. She was briefly off of propofol for an hour and a half, and then it likely metabolized out of her body. She came out moving, fidgety, restless, and they deemed that as a failed awakening trial, resumed sedation, deemed it as a failed breathing trial, saying, oh, she's not ready to be extubated. They didn't screen her for delirium. She got no early mobility. So this is likely because of delirium that she became so restless, but really we don't know why. Doesn't seem like there was much investigation. Doesn't seem like she was allowed to communicate, express her needs, say why she was fidgety and restless. Instead, sedation was automatically resumed. So day 3, at least, at the latest, she should have been extubated. And yet she was re-sedated. Now at this point, she is sedated because she's intubated, and intubated because she's sedated. Her delirium is undiagnosed and untreated. It's likely happening because of the sedation, and yet we are giving the same thing that's causing this acute brain failure. And this continues. And when we had a failed breathing trial, we should have zoomed out and looked at why. Maybe she had a high respiratory rate. She was breathing faster. Okay, but why was she breathing fast? Was she scared? Was she in pain? Was she in withdrawal? Was she having a hard time breathing? Or was she in delirium? But instead, without that critical thinking, without saying, okay, why is she behaving this way? We instead looked to chemically restrain her, stop the breathing, stop the movement, and just keep her on the ventilator for longer. Many of these causes of failed breathing trials are rooted in ICU-acquired weakness, delirium, which are both treated by early mobility. But instead of applying the bundle to her, she was continually sedated and immobilized. And this continued in day 4, day 5, and now by day 5, she's developing a pressure injury. Day 6, she's now gets a brief break in propofol, gets wiggly, they resume the sedation, and on day 6, she finally gets her first delirium screen, and she's positive for delirium. It took 6 days to check her brain, to assess for acute brain failure. this is really concerning. Day 7, now her ventilator settings are gone up to FiO2 90%, PEEP of 10. So it looks like she's developed a ventilator-associated pneumonia. That wouldn't have happened had she been extubated on day 2 or 3. And day 8, they're still treating her ventilator-associated pneumonia. And now we're getting a lot more pushes of midazolam. So now the propofol dose is increased. It's pretty maxed out. The fentanyl dose is almost maxed out. Now she's getting pushes of benzodiazepines on top of that and more oxycodone. Day 8, propofol is still extremely high. Fentanyl's high. Those doses are high. She's still getting pushes of more sedatives on top of that, and still delirious. By I missed a slide. So day 9, this continues. By day 10, someone finally comes along and says, this is crazy. Her lungs aren't sick anymore. She needs to be extubated. So they take everything off and extubate her really quickly, and it puts her on high flow. And she doesn't really start moving until day 11. She starts kind of turning in the bed. Now day 12, she's on a nasal cannula, and physical therapy finally gets to her and gets her to a chair. Day 13, she starts taking steps in the room. Day 14, she leaves against medical advice. She has a deep tissue pressure injury, so stage 3 pressure ulcer, cognitive impairments, and requires a walker for very limited mobility. I don't know what happened to Diane after that. My concern is that she was at high risk of being readmitted to the hospital, whether from falls, from severe cognitive impairments, from an infection and that deep pressure injury. We greatly changed Diane's ever because of failing to practice the bundle. She came in for pneumonia. She likely could have been walking out of the ICU on day 2 or 3 and gone straight home. Instead, she hobbled out with a walker, extremely confused, extremely damaged on day 14. This cost Diane her quality of life, perhaps her life after the ICU, and she is still at high risk of dying after leaving the ICU. This cost the team lots of extra work, lots of moral injury. Sally Finney said in the comments that she's worked as a nurse for over 20 years. And this is the first time she's hearing survivors talk about this, and this is going to change her care. So I shared this not to increase that moral injury, because we're also going to go to another example of how we can change this. We can turn this around. We can't fix this problem until we confront it. So we have to see what we're doing for what it is and look at our process of care as a whole and recognize that patients are not sleeping when they're sedated. That sedation is not necessary just because someone is intubated, and it comes with a high price. And had Diane been seen as more than just a meth addict, had we allowed her to be awake, communicating, telling us what she needed right after intubation, her entire life would have been different. And let's look at an example of this. So this is Megan Wakely. She is a 32-year-old female that was admitted to an outside hospital. She has a history of alcohol use, PTSD, benzodiazepine, and marijuana dependence, likely rooted in her PTSD. She's malnourished at baseline, so she shows up to her outside hospital in septic shock and alcohol withdrawal with alcoholic leukopenic pneumococcal pneumonia. So she has really bad pneumonia. She's got bad sepsis. She's also withdrawing from alcohol. They intubate her, and of course, they sedate her, and likely deeply, with benzodiazepines. And she lays there, brewing in delirium, wasting away in her muscles for 8 days. And her lungs continually get worse, and the team is preparing her family to discontinue life supportive measures to take her off the ventilator. And they decided to have her shipped to an awakened walking ICU. So when she gets to us, she's on a PEEP of 14 and 80%. We do an awakening trial, and she comes out so severely agitated that she actually bit through her endotracheal tube, which is probably the only time I've really seen that. It's obviously an emergency. She was resedated, re-intubated, but we didn't just say, okay, that was failed. That's too dangerous. Her lungs are sick. We have to keep her deeply sedated until her ventilator settings are minimal. Instead, we thought, wow, she is severely delirious. She has a history of PTSD. We don't know exactly what happened in her life, but something happened, and she's at high risk of reliving in her brain right now We didn't see her laying there lifeless with her eyes closed as sleeping. We saw her at high risk of dying, of losing the ability to care for herself. She's a young mother. She has a daughter to go home to. We knew we had to protect her brain. We also knew that her lungs were extremely sick. Her lungs would benefit from mobility. Her ability to survive and live a life after the ICU depended on her being awake and mobile right then. So we bridged her to a better sedative, to Precedex, got her awake, and got her walking. And this is one of her earlier walks. It wasn't pretty. She was delirious. She was weak. And Megan told me that she woke up walking. She came back to reality, realizing that she was intubated on the ventilator, that her family was there while she was in the middle of a walk. And I'll bet it was her third or fourth walk. But that's when she realized what was going on. And you can see her family. She's got her sister pulling the IV pole, her brother in front of her as well. We've got some students. We had a whole entourage, extra people. But she had no idea what was going on during this. And yet we walked her, because that's how you treat patients with a delirium. You mobilize them. You don't resedate them. And at some point when she came to, we immediately gave her a pen and paper. So we stopped the walk, had her sit down, and she wrote, the first question she asked was, "Where's my daughter?" For any of you that are parents out there, if you've been living this world of terror, and maybe your kids are involved in that alternative, graphic, vivid reality, and you want to know where they are and make sure they're okay, if you weren't given the tools to communicate, would you not go ballistic? Would you not act out? Would you not be panicked and mortified? But answering her questions about her daughter, that she's safe, she's okay, here's where she's at. Then she asked, "Where's my dog?" "He's safe, he's okay, we'll bring him tomorrow." She calmed down. And you can already see our CNAs already starting to do her hair. I mean, we just had to find her as the human and figure out what mattered to her, what she needed. Was she in pain? Was she anxious? Was she scared? And treat those things so that we could treat the rest of her body, not cause further damage. And so after that first walk, she was exhausted. She slept. We turned off the sedation. We turned off the Precedex, never needed it again. When she'd wake up, she'd be a little bit anxious. We'd walk again. And we did this cycle. And after 48 hours, she was back to reality. She could be unrestrained. She could communicate. She preferred to sit up in a chair. So in this picture, she's on a PEEP of 18 and 100% with a chest tube for cavitary pneumonia. And yet she's smiling. She has her thumbs up. She's so grateful. She was one of the first patients or people that I told that I was pregnant. At the time, we had such a sweet bond. It was fun to take care of her. So we use these survivor testimonials to regret our careers, not to be burdened with guilt, not to stay in the past, but to look forward to the future patients with hope and optimism, that we have the tools to give patients a much better chance to survive and thrive during and after the ICU. And I'm happy to answer any questions right now or even long after. This is a QR code to my website where you can email me. I'd love to help answer questions with Bill and Dr. Ely. Any questions? Bill, did we get questions during?
I have a question.
Oh, go ahead.
So I think I heard that agitation is a criteria for failing an SAT. And I feel like, just in my personal experience, I feel like agitation is a very normal way for somebody to wake up from sedation. Like, think of like the last thing you remember is you're in your house, you can't breathe, the paramedics call, and then you wake up in an ICU with a tube in every hole. I feel like waking up agitated is like a very normal way to wake up from an SAT. So I've always found it a little bit peculiar that we consider failing an SAT waking up agitated, where in my opinion, that's how anyone should wake up from sedation. And I want to know like other people's thoughts on that.
Sure. Bill, I'll reply and also make a couple of comments about some other things that were written in the note. Can y'all hear me okay?
Yep.
Sure. So that's a great question. And there's been a lot, Kaylee, when you were talking, there was a lot put in the chat that you'll have to catch up on later, but some really ripe and important thoughts have been shared. When we set up the original ABC study, that was back before we had the whole ABCD bundle. We thought it was called Awakening Breathing Coordination. So we were trying to pull together the awakening portion, which was nurses, with the breathing portion, the SBTs, which was respiratory therapists. So we were trying to de-silo the nurses and the respiratory therapists so they could work together. That was our original idea, and that was designed back in 2004, 2007, that period of time. We published it in 2007 in Lancet, I think. Tim Gerard's the first author. And those data, which is where it derives what you said, waking up agitated is a failure criteria, that comes from that study. But before I talk to you about that, the answer to your question, I want to say that was the first study in all of critical care published in Lancet, which finally showed that removing sedation improved survival. And nobody thought that was the case, that was going to be the case. But all we changed in there was we cut propofol in half, we cut benzos in half, we cut narcotics in half, fentanyl. And at the end of a year, get this, at the end of a year, the people who had those spontaneous awakening trials, SATs, which was the shutting off of sedation, were 15% more likely to be alive. And not relative risk. Like if the cardiologists take mortality from 2 to 1.5%, 2% to 1.5%, so they lower it by 0.5%, then they consider that a 25% relative risk reduction. So 2 down to 1.5 is 25% of 2. That's a 25% relative risk reduction. Here I'm talking about a 15% absolute risk reduction. In the former example, that would be a 0.5% absolute risk reduction. I'm talking about people, instead of dying 50% of the time, their mortality goes all the way down to 35, so 15% absolute risk reduction. That's a huge difference in survival, and the only thing that we did to improve that survival by 15% was turn off sedation. So, but when we were doing it, we were aware that it could be dangerous. We didn't know it was beneficial yet, so we didn't have these answers yet. So we set up failure criteria. And one of the failure criteria was extreme agitation. Now, that is supposed to mean dangerous to self or others. Meaning if you turn off the sedatives and their agitation is so bad that it's actually physically dangerous to self and others, nurses, then we have to turn the sedation back on just to protect people. And we do that by turning it back on at half the previous dose. But generally, going from a RAS 0 to +1 or -1 to 0, just a little bit of agitation, you're right, is not a failure criteria for an SAT. It's just when it's overtly dangerous to self and others. Now, the other thing I want to comment on, and I'll shut up, is that a lot of banter, a lot of conversation just took place in the chat about how much work this is. And I'd like for Kaylee to respond to this because she's a bedside nurse and I'm not. There's no doubt that you have to do something physical to wake somebody up, get them out of the bed and walk them. I mean, that is an activity, and that is going to take some work, okay? Now, I think that the overall sum of the amount of work to do that the benefit is way outweighs the gain, way outweighs the cost, because people get out of the ICU faster, they live more often, they have less delirium, less coma, less ICU bounce backs. I put all that in the chat. So the benefits are massive to this, but yes, you have to mobilize the patient, and therefore it requires work. The staffing model was asked. The staffing model in these ICUs where we do this is a 2-to-1, 2 patients to 1 nurse, okay? It is not a 1-to-1. We do have some ICUs in Scandinavia, for example, that do have a 1-to-1, but none of our ICUs in the United States that I'm aware of have a 1-to-1 nursing ratio, unless the person's on CRRT, which is continuous renal replacement therapy. Usually a nurse only has 1 patient when they have a ventilator and a patient with CRRT machines in the room. So most of these are 2-to-1, meaning that, I'll tell one funny story. We had a person come up from Mississippi, and they wanted to see what our ICU looked like. And they, at the end of the day, they looked down the hall and they said, look down the hall right now. So I looked down the hall with them. And they said, do you see that right now there's not anybody on a ventilator walking in the hall? But earlier that day, there had been people walking different times of the day on the ventilator. And they said, when I came up here, I was just unrealistically expecting that all day long there'd be ventilators walking all over the place. And so I think sometimes people get afraid of how much work that will be, realizing that's not going to happen. You've got
it's not your place to say whether or not like he needs a walker, or if he can have one. Like,
I don't know if that person's talking to me or if they're talking to, but what I was getting at is that of your 10 ICU patients, 3 or 4 might walk that day, and it's not all day long. It's a period of 10 to 15 minutes while they're walking, and now it's another 10 minutes to prepare them and 10 minutes to get them back in the chair and all that. So it absolutely is work. But Kaylee, can you comment about this? Is it just too much work? Is it not plausible? Why is it feasible?
Yeah. So my first job in critical care medicine was in this awake and walk-in ICU. And like Dr. Ely said, normal staffing ratios, 2 patients to 1. Physical and occupational therapy obviously prioritized the ICU, but they also had to go to the rest of the ICU, our rest of the acute care floors as well. Our respiratory therapists had to go to the acute care floors. And as well as the ED and labor and delivery. So it was a pretty normal ratio. The difference there, though, is that this is an ecosystem that has done this for now over 25 years. So there's a lot that goes into the staffing required to do this in terms of staffing expertise and skill set. So when I train teams and they're starting this out, a lot of times they'll email me and they'll say, oh my gosh, it took us 45 minutes to get a patient to the chair. We can't do that for all of our patients. And I say, absolutely not. But time yourself next time you do it. Time yourself next time you do it. I think about proning. It used to take 8 people and 45 minutes to prone someone. And now it takes 3 people and 10 minutes. You flip them like pancakes. So it's a skill set that needs to be developed that is not being developed. It's not being trained because it's not part of our process of care in many ICUs. So when you start out, it takes a lot more people and a lot more time. So we do need the staffing to allow that luxury and that time to figure out the workflow, the lines, the drains, get patients ready. So that's part of it, is staffing, skill set, and expertise. The other part of it is the timing. So when we automatically sedate patients, and think of mobility and waking patients up as a back end thing. So once vasopressors are off, once the ventilator settings are minimal, now we'll do those things. Now you've got patients that are delirious, impulsive, sometimes combative, or extremely lethargic. And all of that increases the workload and how many people it takes to move them. Now they're extremely weak. So instead of patients sitting themselves up out of the bed, walking themselves to the chair, holding onto a walker, now you have 5 people trying to hold them up at the side of the bed. That's a lot more work. So staffing is optimized when we minimize the harm that we're doing to patients. So in the wake and walk-in ICU, patients were immobilized doing their highest level mobility, which was usually walking, within 12 hours after intubation. A lot of times, even sooner than that. It was kind of a conveyor belt. You're going to get 3 mobility sessions a day in the morning, afternoon, and evening. So you get intubated at 6 in the morning. Well, 9 o'clock comes along and we're checking you for mobility. You ready to go? If not, okay, we'll check you back in the afternoon. And so they get just sucked into this well-run machine. But it takes a lot to develop that machine to make it so efficient. So I just see with teams, initially, it takes a lot of extra people. It's stressful. You have to think through every little thing. 6 months, a year down the road, they've got their process down and they've got it quick. It takes a lot of collaboration with the different disciplines. So there's a lot of logistics that have to go into making this sustainable. But we also have to consider how unsustainable it is to keep patients intubated for so long, to keep these rates of delirium. So the example that I gave of Diane, she spent 7 or 8 extra days in the ventilator. From that same team, they gave me another example of normal patient care there. And between these 2 patients, I estimated 10 to 12 extra days on the ventilator. It's a 22-bed ICU. If that's a normal process of care, and between 2 patients, you've got 10 to 12 extra days, and maybe, 4 extra days in one patient, 2 extra days in another patient, that adds up. You're taking patients down to MRI because now they're not waking up. Now they're not responding. You have to rule out a stroke. you're taking 3 people off the unit for an hour and a half just to go image someone to rule out certain things to then diagnose hypoactive delirium. So we are doing a lot of work. So it's an exchange in efforts, and it becomes much more efficient and much more enjoyable. So what I hear from most nurses after this has been implemented and they've got the process down is, wow, this is so much easier. We know that delirium doubles the nursing hours required for care, increases time in the ICU by almost 5 days. So what they notice is, wow, patients are more fun to take care of. I know what they need. I can treat them. I can trust them more. I don't have to be constantly running in and out of the room to make sure they don't get out of bed or pull out their lines and tubes. And they get out of the ICU sooner. Like, everything's just better. So as a nurse, we appreciate that. And so there's that. And then with the levels of agitation, like Ano said, when I train teams, we take out subjective terms like agitation. So agitated, I think when those SAT parameters say agitated, like Wes said, it should be severe agitation. But instead, we should be using RASS scores. So dangerous behavior is +3 or +4 on the RASS scoring. That's when they're trying to pull their lines and tubes out or they're combative to others. But instead, when we use these very subjective terms, agitated is being used for a RASS of +1 when someone's fidgety and uncomfortable. So we really need education into our teams of what is agitation, what is the RASS score, how do we use it, how do we make sure that we're being very objective in how we're communicating patient's behavior and how we're responding to it. So yes, severe agitation may be a failed awakening trial, but that should lead us to maybe use a little bit of sedation to get them to a RASS of 0 to +1 and to mobilize them and to clear out the delirium and to get to the bottom of why they're behaving this way instead of turning to chemical restraints and masking all the symptoms and dehumanizing our patients. But that is a very different approach than what we are culturally trained to do in the ICU. But when we take this approach, we do minimize the workload and the staff required in the long run. That address those questions?
Yes, thank you.
Good. I know we're about out of time. It's been an hour and a half, and I think all of you have been extremely generous with your time today. I just want to say that I consider it a privilege to have spent this time with you. We'll let Bill bring us to a close. Thanks so much for caring about this and for letting us to become a part of your community. And reach out to us here at the CIBS Center. Go to our website, icudelirium.org. Let us know how we can be of service to you. And let's all just do a better job going forward and be an advocate, not only for your loved ones, but for other people in the ICU. Talk to the ICU teams about the need to have an awake and walking ICU, to wake people up, to let them get out of bed, make eye contact, to find the person in the patient. You know, this is about touch and technology together, but we can't just do it with technology, and science will never be enough. It's got to be about human and love. And so those are my thoughts. Bill, back to you. Appreciate your time today.
Well, on behalf of everyone, I'd like to thank all the attendees. We are going to be posting this. I'm sure that we'll have some links, and we're also going to, if you would like any additional information, definitely reach out to myself, I think, or Kaylee. We'll put our contact information in the chat. If you look for more information, if there's anything else we can do to help you along your path. Hopefully, we'll be doing some more of these type things in the future. It's been for me, it's been a good experience. It's been kind of cathartic as far as cleaning out some things, but hopefully this has been a benefit, and you'll be able to take this information and apply it to, the other, if you do end up back in ICU or a family member, that you'll be a little bit better prepared. All right. Thank you, everyone.